We're on. So, hi, colleagues. I'm Dr. Parag. I'm a pediatric intensivist at KIMS Cuddles, Kondapur, and I do take care of all this extracorporeal support, it will be CRRT, extracorporeal membrane oxygenation, ECMO, and all those kind of stuff. So, today we're going to talk about how is an ECMO, a little bit about history, machines, and all those kind of stuff, so that we uh, go through all those things and making sure that things are happening over here properly. So, what we're going to talk, how this ECMO and cardiopulmonary bypass work there together, which includes circulation, oxygenation, pump, a little bit about, and what was the prototype of cardiopulmonary bypass or ECMO, what is called as autojector, and then some important discoveries. We'll go through it as a faster, and then what happens with the first cardiopulmonary bypass, then extracorporeal membrane oxygenation, how the modern ECMO came into the picture, and then we'll talk about the machine. So this is when what is happening in India, if you see, we were still doing so many things related to the different kingdoms, North India, Deccan, South India, and all those things. But at the same point of time, there are huge discoveries happening all over the world. That means what I wanted to say is, when we are dealing with this religious things, there are important discoveries happening related to the circulation, that there is a circulatory system, there is oxygenation happening in, there is a load of a blood which carries some oxygen. So in 13th century, we are having this research, and they are very much linked to the various organ perfusion experiments. So this discovery was really important to understand there is an organ get perfused. Then in the 20th century, we had heart surgery, cardiopulmonary bypass, and it actually became a reality that there could be a different circulation other than the body or artificial circulation by 1970. So circulation-wise, there are different discoveries we could see over the time, but initially they said there is a 13th century, there is some gas exchange happening in some of the organ of the body, and they relatively found out it's the lung. And then we have another discovery which says the air and blood mixed it together in 1553. You can imagine how long back. And then somebody says there is a certain thing happening in the body, that the blood is oscillating in some of the tubings, or we call it as a blood vessels now. So we know this in long back in 16th century. And this is very important, what is called as Diu Motu Cordis Sanguinis by Harvey, which is really important, which is kind of a modern physiological concept related to the artificial circulation. That he said there is a pump in the body which is hard, and the same blood is going through the body. So it's not like that there are two parallel circulations. There is a single circulation which is actually making it sure that the same blood is circulating. So, and he said there is a 2-ounce blood is pumped, there are arteries, veins, valves, and all these things. So he actually proposed this theory, and that's why it's really important. So you can imagine when we were actually going through a lot of things spiritually, I would say religiously, there are a lot of different discoveries happening simultaneously. You can see pulmonary circulation, gas exchange, and in medieval period we have air oxygen mixtures and all those things. So there are different discoveries happening when we are talking about religious things. And in 18th century, what we had, there is a defibrinated blood to perfuse porcine kidneys and urine production. So what they did is they put something into the blood, which made the blood kind of go completely anticoagulated, and they're able a porcine kidney and the urine was produced. So it's a really important concept that we can focus the other organs from the artificial. Same thing in 1867, artificial stream of a blood was there. And then we have other discoveries happening in 18th and 19th century. So we conceptualize use of extracorporeal circulation for suturing the heart wounds and all those kind of stuff. And this is really important when we are talking about the extracorporeal circulation. So these are the different discoveries what we saw from circulation point of view. So what we understood in that is there is a pump, there is an artery vein, there is a possibility to make the blood thin. There is a possibility we can actually use the pump to perfuse the different organs. So there was some baseline that we can do these things. Oxygenation, what they found out that when the blood is exposed of an animal to the fresh air, it changes the color. So they understood there is something happening at the same point of time. And oxygenated blood by, so what happens is you take a container, put an oxygenated blood, and you just keep on doing that. And you can actually see the blood color changing into the bright one. This is because of the oxygen is getting mixed with the blood. So this is also something they understood, that oxygenation is also possible outside. So we understood first thing about circulation. Then we are talking about oxygenation. Can we do an artificial oxygenation? And then we have a different discovery. There is in 1882, what he did is he bought a current of air. So basically air coming in contact with the blood, and he could see there is some foaming and color change of the blood. That means there is certain things happening when the air or oxygen coming in contact with the blood. So there was some conceptualization about oxygenation of the blood. Then simultaneously, they found there is something we call as a film oxygenator exposed the film of blood to the air and inclined cylinder. So I will show the diagram. So the air is getting circulated in a cylinder, and there is a blood around, in and around, and there is a continuous and uninterrupted blood flow. And what they saw, that there is some change in the color of the blood. So it's kind of a prototype or initial form of a cardiopulmonary bypass oxygenator. I'm not talking about such a cylinder. A film of blood is there, and it is continuously getting exposed to the air, and that's why you could see there is some aeration or color change of the blood. In 1950, we had a film oxygenator. As we told, the film of the blood exposed to the oxygen. Then we had a bubble oxygenator, that means bubbling into the oxygen into the blood reservoir. It's like a small bubbling what we see when we are boiling the water. And then we try to use monkey lung, auto lung, lot of things to understand, can we do an oxygenation outside? So this is the thing you can see. This is basically a cylinder, and you can see the thin rim of a blood, and the oxygen is all around here. So it's like a centrifugal kind of a thing you say. The thin blood film is here, and the oxygen would be here. And there will be some kind of contact of the air and blood, and which is causing kind of a change in the blood color. And what about the membrane oxygenator? We started saying this membrane oxygenator. When we are talking about the membrane oxygenator, we are talking about oxygenator for ECMO. So there was a lot of sandwich layer, polymer membranes, blood and oxygen layers. Then many issues were there in that, manufacturing issues. There was seepage, air embolism. What used to happen? Membrane, that means, for example, I will talk about it. So in this membrane, what happens is the blood and the oxygen will be separated. So just take it a dialysis membrane. So what happens in the dialysis membrane? The blood is flowing through the small tubules in the dialysis, and the dialysis fluid is in and around that tubing. But in the contrary, in the ECMO circuit, what happens is blood is flowing freely. And the small tubules you see inside the membrane, that is actually oxygen. So blood is free, oxygen is going through the tube. In the CRRT, blood is going through the tubules, small tubules, and the dialysis is free. So usually we have a lot of issues related to making the oxygenator and all, and ultimately we found that this is the best membrane. And initially, because the air was actually pumped into the blood, they had an air embolism seepage issue, but now we have actually taken care of it. So so there are different pumps were available initially. The initial pump is called as a Sigma motor pump. So you can see it's like a typewriter. So it's like a wave formation. So it goes down, then it keep on doing this work, keep on doing this. So it's kind of a straining the tube, and that's why you are able to pull the blood. And then ultimately we had a normal essence billows pump, like a normal motor pump. And then ultimately there were a lot of discoveries happening, and this is what is called as a autojector. So autojector, what he did, it actually involved all the principles and used an artificial lung. Artificial lung means other those things to oxygenate the blood. There were different valves. So in a nutshell, this is a bad blood going into the lung, which is an I would say live animal lung, and it is getting oxygenated back and put it into the reservoir and goes into the patient. So there are different valves involved in this. So this is the autojector. You can see, I would say this is kind of a lung which is getting oxygen, and this is your reservoir, and you're trying to perfuse some of the animals to this. Again, similar kind of a thing. You can see the head of some animals which getting perfused by the autojector. So there are a lot of experiments happen. You can imagine how big this machine is to keep So there is a pool of blood, and the blood is getting oxygenated, coming back to this head. They're trying to perfuse this animal head, and they did a lot of research related to that. You can see this animal head is getting perfused to see whether we can maintain some pupillary response and other things. So, so the first cardiopulmonary bypass became kind of why cardiopulmonary bypass we're talking. It is a precursor of ECMO machine. What they did is the whole body perfusion of a living dog. They try to do it by using two mechanical pump, oxygenator, and all those kind of stuff. You can say a part of an autojector. And they tried in a canine cardiac surgery, is maintained for 2 hours. They're able to maintain the circulation for 2 hours. And then they tried to operate the living animals for the heart valve. So there was initially we talked about oxygenation, we talked about pump, we talked about circulation, and they clubbed together to make some machine which can be used in animals to keep the circulation off for some time, and we can do an artificial circulation. Okay. Other important discoveries happened over the time is we got ABO blood, because definitely blood is an important part of an ECMO. So we had an ABO incompatibility, grouping, and then we have RH factor, then blood transfusion, anticoagulation, very good important, because this is very important. The canine liver extract prevents clotting from blood. We saw that they actually saw a canine liver was there and the blood was there, and they said the blood was not clotting, so there was something coming out of this. So heparin was discovered. Then we had a protamine to prevent the effect of. So all those discoveries are important when you're talking about an ECMO, because it's an integral part of an ECMO. So what happened over the time in 1930s and 40s is they tried to do a cardiopulmonary bypass, because it is a precursor of ECMO. ECMO is kind of a smaller version of a cardiopulmonary bypass. So what they did in 1930s with the massive pulmonary embolism, they gave a concept of cardiopulmonary bypass and worked extensively on that concept over the time when they required this for one of the patients. So the lone bypass surgery is on. So basically they were doing cardiac surgery without bypass, but at the same point of time, they thought about the concept, can we bypass for some time so that we can stop the heart and do a surgery? So they did some successful cardiopulmonary bypass in cats. They were able to stop for 20 minutes after long-term survival. And then in 1935, they did it for almost 2 hours. And they worked extensively on this heart-lung machine concept. So in between, a lot of people have tried this novel concept. You can see this is an adult who is actually giving this circulation to a kid for the perfusion. So that means you can stop the heart and use a adult as one of the supporting circulation systems, like an artificial circulation. So this is one thing which they have tried in during that point of time. And in, I would say 1950s, there was a sophisticated bypass machine. So you can imagine such a huge machine, and this is an oxygenator. Now it has come as a probably 1/10 size of this. So this was the first oxygenator and cardiopulmonary bypass machine. And the area was, now we have a machine with a huge area, but it's as small as, I would say, a couple of balls. They are more refined. They did many surgeries, bypass grafting. There was point of time. They did the first cardiac transplantation in 1967. So simultaneously, there was a lot of research happening on ECMO, extensive research on cardiopulmonary bypass. Can we do it for short time? Long-term solutions. If I wanted to do it for longer time, the patient is not able, can I do? And then there was change in the membranes and all those things. And then so as I told you, so this was a concept which is kind of a recent ECMO membrane. So you can see this is a tube, and the oxygen is going through the tube, and all around is the blood. Normally, as I told you, PRIT machine, the blood goes through the tube and the dialysate fluid is in and around. But here is different. So the fibers carry oxygen, and the rest of the thing is blood. So that's why the chances of clotting, air coming, or air embolism is very less. So this is the concept: capillary channels, increased surface area, more blood is coming in contact with the oxygen. And then we had a birth of ECMO in 1970s. And just to let you know, the birth of ECMO happened because of the neonatology. Neonatology has given ECMO to the world. And let me tell you another thing, why we kept on using the ECMO for such a longer time, because neonatology kept on pushing ECMO, because neonatology is the one thing we had a maximum good survival respect to the ECMO. When the other trials were going on and they're showing the ECMO is not good, not good, not good, the newborns were kept on telling and showing that ECMO is the best strategy. Initially, they used extended bypass to take care of the ECMO. Then hollow fiber oxygenator came, as I told you, similar to CRIT dialysis chamber, and there was a cross flow and all those things. So there was a lot of research going on there. And 1970s, Report the first adult ECMO survivor. This is basically an adult who had trauma, pulmonary embolism, and all those things, and they put this person on the initial form of an ECMO, and they thought, and this patient improved. And 1970s, there was RCT on ECMO and ARDS, and there was only 10% survival. So they stopped it. They said, this is not something this is going to help. And for 15 years, nothing was done. Nobody thought about ECMO. But Bartlett, Globo, and Gattinoni kept on using ECMO, and they kept on showing that there is something happening, and everybody knows about this Esperanza. The first child, I would say, pulmonary hypertension child, PPHN child, put on ECMO. The child had a severe respiratory distress syndrome, and you can imagine how big this machine was. This was the first patient I was talking about, trauma ARDS patient, and this is the second. And there was a very good commentary by Dr. Bartlett. You can search on Google what was his journey through the ECMO. He kept on doing a lot of extensive research, and this was the first surviving patient on ECMO, newborn. And newborn is the one thing which has given ECMO to the world. So after that, this ECMO rocket just launched like anything. You can see during this time, there was almost limited use of 1980s to 2000. There was nothing, bridge to transplant and all those things. And after that, it's just blown away. There was a Caesar trial, and then in 2009, we have an H1N1 influenza intake. At that time, it just blew because it has saved so many lives that the things became absolutely amazing. 1982, still the adults were not using ECMO. 45 units, 55% survival is amazing. This all kids gonna die, and 55 survived. Again, there are studies where there is 70 to 90% survival on ECMO. And after 1989, the ECMO Society was formed to support this strategy all over the world. So what has happened during this time was there was a good different membrane came, machine, manpower, perfusionists, anticoagulation circuits, anticoagulated circuits, different pumps, and so all these things are happening together to make the ECMO more successful. And you can see in H1N1 pandemic, we had 71%. So that was an amazing to push ECMO into the ECMO is in nutshell, 1960 to present. Here, what has happened is there was an increasing use of ECMO because of H1N1 pandemic, and then again we had it in 2019 because of the pandemic. And there were different things were happening about change of the membranes, anticoagulation, and all those things. So things became absolutely in this. We're gonna make this very short. So modern ECMO is given by neonatology and H1N1 pandemic, and now it is sustained by a lot of other ARDS coming into the picture. And we had a lot of, I would say, research and discoveries related to the pumps, anticoagulation, and membranes. So centrifugal pump, what is basically centrifugal pump is, it's kind of a magnetic pump which creates a whirl. So there is no centrifugal, so there is no force on the tubing or such kind of a thing, which is because of mechanical friction. So there is a less chances of having a injury to the RBC. And as I told you, there are a lot of things happen together: heart and lung transplantation, ventilation injuries, severe ARDS survival, and all those things. So the ECMO was established, and over the time there was a price reduction. There were different protocols, ECPR, extensive cardiac surgeries, long-lasting circuits, and all. So they became so. So what is like basically? So now we had an established ECMO system. So what is exactly the goal of ECMO? So it's very simple. What it does is siphon as much as blood from the venous circulation. So you have this ECMO, you can imagine, you suck as much as blood possible, deoxygenated blood possible, by a pump, push that blood into the oxygenator, make it oxygenated, so remove carbon dioxide, put oxygen back into the blood, and return it back to the, as I would say, as best as possible. So siphon as much as blood, sucked by the pump, put it into the oxygenator, give oxygen air, whatever amount of you required, and put this blood back either into the artery or into the vein. If you are putting into the vein, so remember, when you are removing the blood, always you are removing from the deoxygenated blood. So it has to be venous. So remove venous, put it back either into the artery, which is called as a veno-arterial ECMO, or put it into the back into the venous, which is called a veno-venous ECMO. So what are the different types of extracorporeal life support? So we have different extracorporeal life support. So one is ECMO, extracorporeal membrane oxygenation. You have ILA, what is called as interventional lung assist. Then you are not bypassing the heart, but you are just bypassing the lung. Then you have ECOR, which is called as a This is basically like a dialysis just to remove the carbon dioxide, and then you have a left ventricular assist device. So what it means is you are actually trying to help the left ventricle. There is no oxygenation involved in this. So this is a different. So one is ILA. What is ILA? Basically, there is no pump. So you can imagine you put a one cannula into the pulmonary artery. So the right ventricular ejects blood into the pulmonary artery, and the cannula is there in the pulmonary artery. Blood comes out, goes to the one membrane where you are giving oxygen and removing carbon dioxide, and the blood comes back into the left atrium. So you are bypassing the lung. You are not bypassing the heart. So it comes to the LV and ejects into the whole body. We call it interstitial lung assist or interventional lung assist. So you can see the blood is coming out, going back. Then you have a VAD. What is that? Ventricular assist device. That means there is no oxygenator, only pump to support the failing heart till recovery or transplant. And in ECMO, we have a VA ECMO, VV ECMO. There are other different combinations, but this is the most important. That means we are taking the blood from the vein, putting the blood back, air. We are taking the blood from the vein, a larger vein, and putting back into the artery. We are taking it from the vein, putting back into the vein when the heart is absolutely doing good. So now when to start ECMO? Is there any category or things? So let me tell you, most of the studies are from the adult. There are different scores and all these things, though most of them are universal in the pediatric as well as neonatal ECMO. So this is a one score called as a Moore score, where they have used PF ratio, chest X-ray, PEEP, compliance, and you see if the Moore score is more than 2 or PF ratio is less than 15 mmHg, you should be considered for transfer to an ECMO center. So if you start seeing any of these things, this is to identify the patient early to initiate the ECMO early. So what were the previous 90s indications? Severe respiratory failure, PF ratio less than 100, hypercapnia, PF less than 72, refractory cardiogeny. So there is generic. Over the time, it becomes more and more refined, and ALSO has given it more compliantly. So hypoxic respiratory failure, let me tell you, these are all standard guidelines with respect to the adult, pediatric as well as newborn. Consider if the PF ratio is than 150, indication if the PF ratio less than 100 for more than 6 hours. Remember, don't push your boundaries. If it is like that, you are not going to help. And if you are trying to help, you are actually damaging the lung. CO2 retention, despite P flat of more than 730, severe air leak is there, lung transplantation, immediate cardiorespiratory collapse is there. So these are all very prominent indications. Don't try to push yourself when your sleep activity is more than 30 mmHg. Because what you are doing is you are kind of riding on the kind of a tired horse, which is actually going to fail if you keep on ventilating it for a longer time. So indications and contraindications as per the disease paper in NAGM, hypoxemia, where you have a PF ratio, uncompensated hypercapnic with acidemia, high platy pressure, relative contraindications are there, but these are not absolute. So if you are having ventilation more than 7 days, high FiO2 requirement more than 7. So basically, why they are saying relative contraindication means because you have already exhausted the good time where you can actually start ECMO. And you're not able to do that, that means there is a less chance that the lung might recover back. But that is not a absolute contraindication. The only absolute contraindication is that means whatever you do, so there is a brain dead. So whatever you do to the heart, lung, the brain is not going to come back. Or you have such a bad anticoagulation disorder that you're going to bleed to the death. So nobody would do an ECMO during that time. So there is no absolute contraindication, but relative contraindication is, as we say, mechanical ventilation more than 7 days, major immunosuppression, CNS bleed, major CNS damage, increased risk with the age, but you can take a call. But poor outcome, adult definitely have a poor outcome, specifically not in newborn, because newborns relatively have a very good outcome. Length of ventilation pre-ECMO. So if you have ventilation more than 7 days before starting on ECMO, relatively poor prognosis. Diagnosis, other organ injury. So you have acute kidney injury and you are going to put on ECMO, definitely the things are bad. If you don't have an acute kidney injury and you're putting back on ECMO, relatively better outcome. And you have a different complication. So different strategies for ECMO. This is a very important step. So you have a refractory hypoxemia. As we said, anything more than 2. And when it goes to 3 and 4, definitely you're talking about refractory hypoxemia. So in a refractory hypoxemia is associated with cardiogenic shock, that means heart is also not functioning, lung is also not functioning, or all other heart failure. So you go on a veno-arterial or veno-arteriovenous ECMO. So basically what you mean to say is you get the blood from the vein and put it back into the artery. Simple. Because you have to bypass both heart and lung. Because your hypoxemia, lung is bad, heart is also bad. But if it is due to hypoxemia, that means so you have a hypoxemia and cardiogenic shock, and you feel there is a primary cardiac problem. It could be a myocarditis, cardiac dysfunction, then go on a veno-arterial. But if you feel the cardiogenic shock is because of the hypoxemia, that means you are not able to oxygenate, that's why heart is becoming weak and weak and weak, then you can take a chance and put them on veno-venous, thinking that once the oxygenation improves, the heart will improve. So you can think about putting on veno-venous if you feel the cardiac dysfunction is because of the hypoxia. And there is no shock, nothing, everything looks good, inotropic support is not there, you can think about putting them on the veno-venous system. Then you have a refractory hypercardia. The carbon dioxide is so bad, so increased, and it is associated with hypoxemia. That means the lung is really bad. Definitely, you're going to think about veno-venous because my heart is good. But there is no hypoxemia. Then there are what you call it ECMO. It's like a dialysis machine where the blood goes very smooth, not slow, and the carbon dioxide is released because your hypoxemia is not a problem. So you don't have to really oxygenate the blood. And in the Indian context, what you should consider is patient is too sick to initiate the ECMO. If you feel they are too sick, you don't want to actually push on the wall. Is there any other organ injury or severe organ damage like a brain damage, kidney damage, and all those things? Patient is how previously managed in the referring hospital for 10 days, 20 days, 14 days. Though there is not an absolute contraindication, but it makes you prognosticate and counsel the parents appropriately. Reversible, irreversible pathology. If you are thinking about irreversible pathology, like there is a cancer or there is a brain damage and all those things, I would not put the child on ECMO. CNS, absolutely important, and risk of bleeding. Are they completely anticoagulated? There is a very high risk of bleeding. Like example, the patient with the dengue. So if the patient with the dengue with the platelet count of 1000 and INR of 6, I would never try to put these patients on ECMO because they will bleed to death. Recovery or transplantation, if you're talking about heart lung transplantation, other organ support, whether the child is on or the newborn is on, CRRT, peritoneal dialysis, and all those things, you can't really give a justice by starting ECMO in this patient. Other special issues are ethical, transport, financial supports are there. So we talked about evidence-based ECMO, which happened between 2000 to 2009. Very important. Short, these are adult studies, but just to let you know, initially we had a setback when we were talking about ECMO. So this was an adult study where VA ECMO was considered with mechanical ventilation, and what they found, there is a 90% mortality in the ECMO group, and they stopped using this kind of a strategy. ECMO versus conventional ventilation in ARDS, what they found, there is no difference in the survival. Probably the choice, probably the way they are ventilated are absolutely different. Then came the swine flu 2009. I would not say nail in the coffin, but probably something which has helped us amazingly. So there are spurts of cases all around the world, all around the globe. And simultaneously, what would we see? The ECMO registry started going up and up. There are a lot of patients on ECMO, and the survival changes from 60 to 80%. Can you believe? Those patients supposed to die started staying saved because of the ECMO. It was actually one of the diamond in the crown during the 2009 H1N1 pandemic, and this has given really a momentum for the ECMO in the world. And you can see the survival, those who had a conventional management. So this is the blue line, which is suggestive of conventional management, and the red line or red bar is basically ECMO. And you can see conventional management, so ECMO was relatively better when compared to the ECMO. So 63 survival in ECMO group and 41 in the conventional mechanical ventilation group, and it has really pushed up the ECMO to the different level. Same thing here depicted, 63 ECMO group, 47 mechanical ventilation. These are all adult studies because to find H1N1 and put these patients on ECMO in pediatric groups were a little bit less, and neonatal was also less. And then we had this study published in NAGM for severe acute respiratory distress syndrome. And why this study was really important was absolutely well-planned study. There are a lot of randomization happened and went into the different arms. And there was a crossover. If somebody was not able to maintain on ventilation, they crossed over to the ECMO. So the survival, there was a better to do the control group. 20 out of 34 crossover patients died on ECMO because they were actually started late. For example, first patient came on, let it be control group, which is mechanical ventilation. Other patient randomized to ECMO group. When the patient is not improving on the control group mechanical ventilation, it was crossed over to the ECMO group. So that means we are actually starting an ECMO late. So here, 20 out of 35 means those who are not actually able to maintain the oxygenation on control group, they were crossed over to the ECMO group. So what has happened is they were actually started on ECMO late. And what happened in this patient, they died. The lesson learned is don't wait too long, and that's why we are talking about start on the first 7 days. So almost 5,000 patients hospitalized in influenza, 250 patients from uh, American, and 251 patients at ECMO centers in ICU. So they put a lot of patients. The mortality was really amazing, and they have really good improvement with ECMO in ARDS. Thousands of patients were put on ECMO, and considered that almost 50 to 60% of them has actually improved survival. And then came this year's trial. What they did is those who are underwent a cardiopulmonary arrest in the hospital, they kept these things ready and they put directly them on ECP. This is called a VCPR. Like CPR you have when you are not able to kind of get the return of circulation by doing a normal CPR. What you do, you keep on pressing them and put them on ECMO. So bypass heart and lung and just we create an artificial circulation. So they kept all those things ready, but it was not found to be that much helpful. But the outcome was really amazing, and they were found that there are a lot of patients be on ECMO for a longer time and still they improve. So they give, it's not like that you should do an ECMO for 7 days, 10 days, or 5 days, something like that. You can actually keep them on the ECMO for longer time and still they recover. The largest ECMO, pediatric ECMO, you can see it's almost for a year, and the child came off from the ECMO. So it is always optimistic. And then came the COVID-19, which has given kind of ECMO again weightage. So this is a registry, ASLO registry, I would say, long back. So huge amount of patients on ECMO, and there is a good improvement. North America, Europe, Asia, good amount of patients went on ECMO. And 90 days ago, so almost 415, and in hospital mortality is 30. So a good kind of a dictum supporting utilization of an ECMO in this patient when we are actually lack of conventional management. Coming to pediatric and neonatal COVID on outcome, so almost 50% discharge home. Can you imagine? Amazing. They had a very less complication if you consider 4% and all those things. Though there is almost 30% death, but these are going to die, and actually you saved with ECMO. So it's really a good kind of things you'd see when you're talking about ECMO. This is a registry with related to the neonatal and pediatric. You can see the numbers. The neonatal are far more than pediatrics, almost around 46,000. And look at that, the survival. Or transfer 65%, pulmonary 73, cardiac 42, ECPR 40. So that's what I'm telling you. Newborn is the one who has given ECMO to everywhere, and we should be thinking about ECMO when we are talking about ECPR or really a bad respiratory distress syndrome or PPHN. And similarly, in here also 50 to 60%. As compared to the others, you can see there are not much. We are way ahead of survival when you're talking about ECMO in pediatrics and newborn. Again, this is an ASO registry, 60 to 70% survival in the newborn and pediatric age group. So in summary, and then we'll come to the machine also, it's fascinating. ECMO machines is robust. Now we have a lot of training, upscaling, and we have a lot of proof from H1N1 and COVID, and it's very much evidence-based. So what I want you to think about an ECMO in early, less than 7 days, start them on ECMO, prevent the lung injury. ECMO is not something bad. ECMO, if it's done properly and appropriate time and managed appropriately, they do improve. And we have done that in KIMS. So we have already done 17 ECMOs, and they're doing amazingly well. So make it sure that though there is an audacity of death. Yes, absolutely agreed. But if you don't do it, they're going to die other way around. So this is about the machine. I'm going to talk briefly about the machine. So what are this is a machine, ECMO machine. So you can see this is the main console. This is the main console where you can see this dialer whereby you can increase the RPMs and you can increase or decrease the flow. And there is a power button, there is an on button, there is a clamp button. All those buttons are there. And then you can see it over something, sweep gas. So what happens is this is a blender, air oxygen blender. You can see here 10%, 20%. You can give it FiO2 depending upon you. Things. And this is the flow meter. Flow meter means you have to give flow. You can see there is this small tubing, green tubing coming out of this. And this tubing is getting attached over this. This is an oxygenator. So we are just giving the way we give oxygen, from oxygen. So we're giving just the way oxygen to this oxygenator. And this had a two flow meter, you can see. One is like 1, 2, 3, 4, 5, 6, 7, 8 till 10. And another is an ml. So you can give 50, 100, 200 also. So both flow meters are there. Here you see FiO2 and flow meter, and this is flow. What you give to the machine is called a sweep gas. So 2 liter, 3 liter, because the function of this is oxygenation. The function of ml is to remove the CO2. So if you give more sweep gas, if you give 3, 4, 5, more CO2 will wash out. If you give less, the CO2 will retain. Then you have water bath. So this is called a water bath. If you see, this is the temperature. You can see something 35 mentioned here. So there is a water, sterile water circulating through this, and it is circulating into the membrane. So inside the membrane, there are 3 things. What are the 3 things? One is blood, one is air and oxygen, and one is this water. So all 3 of them will not come in contact with each other. So this keep on going into this oxygenator to what you call the heated water to keep this, I would say, the temperature of the membrane kept it in a proper way so that it is not hypothermia, doesn't happen to the patient, and you can really regulate the temperature. This is an oxygenator. When there is a hand cranking, you can see this is called as a cone. So this tubing is attached to the patient. So from there, this is a cone. Cone means this is a structure. This is an electromagnetic pump. This will roll around. It will create a whirlpool of a blood, and it will keep on sucking the blood. So the blood comes like that. So this is the pump, which is an electromagnetic pump. This is the cone where the blood is getting sucked, and then blood is pushed here. You can see a small black clamp here. This is called as a flow detector. How the machine comes to know this is much is the flow? So it's a flow detector. At the same point of time, it detects any bubble coming into that. So bubble coming into that, if there is bubble comes, this automatically signals this, and the machine stops. Even a small, like a I would say 0.2, 0.3 ml might not start, but 2, 3 ml bubble coming, it is automatically stopped. Because it will not let this bubble go to the patient. Sometimes some bubble might go, but they get usually trapped in the membrane. This is a hand crank. So sometimes if the machine fails, so you have to remove this cone from here, put it over here, and start hand cranking. There is hand cranking means there is something like a rotator thing to keep on cranking, and then you'll be able to see how much RPMs you are giving it. So this is actually assembly of machine. The component of the machine, as I saw, this is the console. Then you have a cone. Cone is something where actually the whirlpool of the blood is created and stuck. Then you have this is that hand cranking. So you can see you have to put this cone over here, and this is a handle which you can keep on rotating. But how you will come to know how much RPMs are there, how much flow is there? So you know that initially when the machine was working at 2000 RPM, you are able to achieve 2 liters of flow. So here also there are small lights are there. If you are actually every time when you are hand cranking, if the 2000 RPM light is getting blinked, that means you are reasonably giving 2000 RPM and you are able to achieve 2 liters of flow. This is a pump, electromagnetic pump, and this is a sensor which actually calculates both flow as well as bubble. So this is a rotaflow. Again, this is a pump, electromagnetic pump. As I told you, it sucks the blood and pushes the blood on. So this is coming from the patient, sucked by this pump and pushed. This is a clamp or flow detector as well as bubble detector. Then this tubing is going into the oxygenator. From this, the blood is coming out. You can see the color of this blood is a little bit more brighter as compared to this blood. Then you have a hand crank, as we discussed. The hand crank, you have to do it with the holding. Then we have a console. In the console, you see this is basically liter per minute. You can see this flow, and this is an RPM. How much RPM is required? RPM at the pump to achieve that flow. And there are different buttons involved. We'll talk about it. Clamp button and all those things. So nothing to much worried about that because your perfectionist will know. And this is your cone. Cone is a part of a circuit, and this is your bubble detector as well as flow detector. You have to lubricate this with something so that there is no air between the 2 modules. So this is an oxygenator, which is important. So you can see this is an oxygenator holder. So this is, as I told you, that green pipe pushing the air inside. So oxygen flow meter. This is a small kind of a nozzle. It is there. This is basically a, so when the blood is going through that, there is going to a lot of heat is going to get generated, steam is going to generated, vaporization will happen, moisture trap will happen. So what we have to do is every couple of hours, we have to increase the flow. We have to increase the flow through the flow meter and open this so that the condensation and all those things go out of the membrane. And then as we told, water bath. So inside what happens, there are three compartments. One compartment, this heated water is flowing to what you call increase the temperature of blood. Then you have the blood, and then you have a small tubules where the air is also flowing to oxygenate. So flow. So this is here what we said. As I told you, FiO2 concentration. We decide about oxygenation and the speed, which is free flow. That means liter per minute, which decides about the removal of CO2. So now, with this, we will again talk about another one. Case, and then we see some videos. I'll go through the case faster. I'll go to the case faster. So this was a 40 days old baby, TTNB, had some TTNB NICU stay initially and had some oxygen requirement, NICU stay for 6 days and all, and had a small PDA, ASV left to right when the baby was small. But everything over the time it became fine, but the child started having respiratory discomfort, cough, cold, breathing issues. Child was admitted outside, started up on oxygen, HFNC, the work of breathing kept on increasing, became hypoxic, got ventilated, intubated, and came to us. So here the child was in respiratory kind of a failure, some hypertension was there, and child was continued on mechanical ventilation. Other supportive management was given in the form of antibiotics, clavicle nebulization, empirical hospital was come. So this was an X-ray which is really you can see there is some opacities on the right upper lobe. Initially settings were tidal volume of 25, we were on PRVC mode, rate of 30, SIO2 requirement 60, pH was reasonably okay. And blood parameters are looking fine, looking like a viral infection. Echo, there was a small PFO, ASD, and small PDA. Remember this with the hyperdynamic circulation. There was a human metapneumovirus, cultures were sterile. The CT was having some subglavial fluid. So we are fine. Continued on mechanical ventilation. Child had a peak pressure of 30 to 32, borderline FiO to 70 to 80%. And CT, we did it just to identify whether we are dealing with something else. So extensive hilar infiltrates were there, and there was a moderate pulmonary arterial hypertension. Why I'm saying remember this small PDA hyperdynamic circulation, which was not active because it was not active because the pH was increasing. That's why the right to left to right shunt was not prominent. On day 3, child started becoming bad. The chest X-ray worsened, the ventilation parameter worsened, chest X-ray, CRP increased. So basically hospital-acquired infection, you can say. You can see the runs are really bad. The FiO2 requirement went up, heat went up, and then you started having the spiral of hypoxemia. You can see the PO2s are coming down. Then subsequently, we need to start this child on high frequency oscillatory ventilation because we are on FiO2 of 100, almost reached the peak plateau of almost 30. And on that also, we have to start inhaled nitric oxide. So we are on now 100% FiO2. We have an oxygenation index of 30, still PO2 of 78. So we are actually pushing the boundaries, satisfying all the criteria related to the ECMO. As I told you, PF ratio less than 100, lasting for more than 6 hours is itself in a criteria for starting ECMO. Here we are on additional inhaled nitric oxide because none of the criteria involves inhaled nitric oxide. So day 4 of admission, we have really a bad luck. So what to do? So we have made a decision for starting on ECMO. So all those things were satisfied. PF ratio for 60 to 70, OI was bad. The child was an epinephrine and norepinephrine in the heart functions was, there was an RV dysfunction, moderate TIA. So now we have a lung as well as heart failure. So what kind of an ECMO we start? We have to start something which will bypass heart as well as lung. We are thinking about taking the blood out of the veins and putting that into the artery. So we made a decision for starting VA ECMO. So we cannulated right IJV into the jugular vein and the right common carotid. So we sucked the blood out of the right IJV, went into the ECMO circuit and came back. And we did a surgical placement at birth. All other things, pediatric ECMO circuit we use. So this is a placement at bedside. You can see the child is on 40 of high frequency, but still kind of an hypoxic and all. You cannot able to see the monitor, but hypoxic, and we were doing this cannulation. We so immediate post, so we put the child on ECMO, we were fine, we were able to achieve all those kind of things. The child initially, after achieving a good flow, I started having some hypotension, the boluses was given and all those kind of stuff was done. The child remained hypoxic and hypotensive. So the child had a massive pericardial effusion. You can see there is a massive pericardial effusion. So what we have to do, we have to put an pit tail, and immediately after pit tail, we could see there is an improvement in the heart function. So this was the pit tail which was put, and the child had an improvement. Actually, we were able to achieve the VA ECMO, and over the time there was an improvement in the gas exchange. We once we put the child on ECMO, we came on the rest setting, so we don't have to trouble the lungs. We just did the minimal ventilatory settings, kept on using the ECMO, and over the time we could see simultaneously there is some improvement in the lungs. You can keep on seeing this X-ray. The X-ray kept on improving slowly, slowly. The ventilatory parameters also improved slowly, slowly. Initially, we were 90%, we were on 40%. Lungs started improving. And we tried to came off ECMO, and over the time on those day 20 to 21, we were able to have an improvement in the lung. So how we know that there is an improvement in the lung? What we do is we stop the oxygen into the ECMO machine. That you remember that nozzle we stop. And in the VA ECMO, we have to do in a different way. We have to clamp the both cannulas. So we have to clamp over here so that there is no blood, it's sucked out, no blood is going in. And then we have to optimize the ventilation and see whether the child is able to do it or not. So what happens, we were able to do, we decannulated the child and did really well over the time. So this is the way one of the patients has actually improved. And there are certain videos I would like to show you how exactly it looks like. There are different videos I wanted to show you. So this is the actual way it looks like. So this is the way we can reasonably do a transport also on ECMO. We have done. So this is a child. We can see this is a child on veno arterial ECMO basically, and this child had an acute kidney injury. So through the same circuit, we started this CRRT, so we can start that. We don't need another access. We have to connect it to the ECMO circuit, and this child is on both VA ECMO and circuit CRRT, which is good. So this is another child who's on veno arterial ECMO. You can see. So this is a video, and you don't have to really kind of sleepy. You can see this child who is on ECMO. You can see this child who is on ECMO. You can see this child on ECMO, and this is the kind, and he's obeying command. He's basically obeying command. If you ask him to move his left leg, he's moving his left leg. See, so you don't have to really keep them kind of sedated. He's moving his left hand. So we can really make the difference by starting. This is a child who is gonna die because he was not able to get oxygenation, but the things are improved. So now briefly we're gonna show you about a machine and some circuit and cannulas. So we'll do that. So so this is actually a ECMO machine. You can see this is the console, okay, and then you have this heater unit. You can see that heating unit, and then you have this. This is basically your hand cranking unit, okay. So you can actually disconnect, and you can see there is a this is basically your hand cranking unit, and if you are able to observe, there are lights you can see over here. So this that you come to know that how much RPMs you are doing. This water bath, and this is a place. This is a place where the oxygenator comes into the picture, and this is your flow meter. You can see this is your flow meter, and very nice. Then We have different cannulas here. We have different cannulas here. So you can see the different cannulas are over here. And then there's an introducer kit. So we have this dilators, different dilators, introducer kit, and different cannulas are there. Depending upon the requirement, body surface area, cardiac output, we use a different cannulas. So that there is an appropriate flow. You cannot use the smaller cannulas or bigger cannulas because you have to use age appropriate cannulas to make it sure that there is a good amount of flow. So this is basically your introducer kit. We have a, so we have this. This is your oxygenator. We'll open this, and this is your introducer kit. This is a brand new introducer kit which actually we use to. This is now, this is your stuff like that. It is different oxygenator. This is your oxygenator, which basically we have to attach to the circuit, and then we have this circuit here. You cannot open this circuit, and it's not transferable. So you have this bi-line circuit comes from the MACA, which is a heparin coated circuit. So I cannot open it. It's very expensive, almost cost around 2 points. So the initiation cost related to the ECMO, it comes around, so basically the ECMO circuit costs around 2.2 to 2.5. We can learn 40,000 each, and then we can actually initiate them appropriately when we're talking about ECMO. So we saw some videos related to them, ECMO. I'll see if I have few other videos. Probably we will discuss about them. It's a lot of the one. But the real story starts now, and real story starts when we put the child on ECMO, because you need a 24/7 perfusionist, you need experienced ECMO specialists who actually able to manage these patients around the clock. And there is a lot of hard work involved in this patient when we're talking about getting the child successfully out of this ECMO. I see one video which would probably show how the blood flows goes from here and there. So most of the things we have covered at this moment. So, uh, so basically, what I wanted to say is ECMO is an amazing kind of a thing, extracorporeal membrane oxygenation. When the lungs are failing and you really wanted to buy time, definitely ECMO is a very good modality. Don't stress yourself in pushing this lung to the maximum capacity by giving higher pressure, higher oxygen. This is not gonna work out. You can try for 24 hours, and if 24 hours if the things are not stabilizing, these are the patients you put on ECMO early. And because more and more centers are doing ECMO, it's now affordable. We can make it a little bit cheaper also. We can make it sure that they go on ECMO quicker and they come back on the ECMO quicker, so that the the cost is also less and the improvement are better. So with that, I would like to thank you all of you. Thanks for listening. And if you have any questions, you can ask me. You can reach on the Pinterest website, YouTube. We'll be very happy to answer your questions. Thank you very much.